Hello, everybody. Welcome to Grand Rounds, usually hosted by Tom Farden, who is on holidays and isn't able to make it today. So for 3 or 4 minutes, I'm working as a locum respiratory physician for NHS Tayside. But once it's done, that's it. I am a GP, or have been a GP in Tayside for about 20 to 30 years. And it was my great pleasure and to meet Michele and the work and get involved with the work she's doing. Gosh, it must be over a year now, Michele, something like that. Time flies.
Yeah.
It always struck me as a very, very useful, important, effective, all those good words, project. And that it's because of that then I
Oh, you've gone on hold there, Pascal. You're frozen. Sound like the Mandalorian at the moment. Okay, Pascal, I think I'm just going to get started because we can't hear you. At least I can't hear you. So feel free to interrupt me when you're able to drop back in. But hello, everybody. I'm Michele Church. I'm the senior lead for Tayside's Macmillan Improving the Cancer Journey service. If you've just joined and you haven't already told me, please have a go at telling me if you know about our service already or not. There's a few yeses, but maybe a few more no's. And I'm sorry, there is a bit of background noise. I'm sure Pascal's still trying to speak to us. Okay, guys, I'll tell you what I'm going to do. I'm going to start to share my screen and tell you a bit about this service. All right. So just navigating Zoom. I'm missing my MS Teams proficiency. Hopefully you can see that screen now. But if you have any issues, please put your hand up and shout. Okay, or put something in the chat because I can't see that. So this is our service. We are now Tayside wide. We've been going for a little while, for 5 years, in fact, in Dundee City, providing a wider Tayside service for people affected by cancer. And we now have link workers in Angus and Perth and Kinross, and I'll give you more details on that in just a moment. Okay, so we're a link worker-led service in Angus, Perth and Kinross and Dundee City, and that's really important. That was decided by a group of people involved in this, that it was important to have local link workers based in community services. Could have easily stuck it in NHS Tayside as an outpatient facility in oncology, but we haven't. We support anyone affected by cancer. So yes, if you have a cancer diagnosis, absolutely, we want to be able to support you. But if you're a friend, a carer, or a professional carer, we will also offer you a holistic needs assessment. We listen to people's concerns. We connect them then based on what they need or want, or both, to a wide range of personal, practical, and emotional types of support. We are not clinicians, we're not a clinical service. We do everything else other than provide clinical care. We currently have 2 websites. So if you want a patient story, we've got a number of films like many services do. And if you're looking for a patient story, and that will speak more to your heart and mind and tell you exactly what your patients will get, please do look at our very short animations, but I'm not going to show you one now. Okay, I love statistics and data, so if I overwhelm you with too many slides and data, I do apologize, but what I really want to share with you today is what the opportunity of the service is. Okay, so a little bit about what we do then. Okay, people can use us, but we're an opt-in service at the moment. We would really like to become an opt-out service. We're working hard with people upstream in acute settings, and together, hopefully with yourselves in the GP primary care setting, we would really like people to come to us and not be put off or stopped accessing our service because of gatekeepers. It's really for an individual to decide if they don't want to use our service. We assess people. It's called a holistic needs assessment. We hear that term a lot, but basically we look at a lot of things that matter to a person, and we help them understand what they might need and be bothering them at any point in time in their cancer journey. We then triage them. We refer people to services that can give them the support. So we're a key connector in a very complex, messy system of health and social care. And we also stay long enough with people to help them understand, did we make a difference? Did you get the outcomes you wanted? And if people don't want that, we also drop off sooner than a review stage. You'll see along this presentation or chat or conversation that I've got a number of red questions. These are my questions. They're things I ask myself every day. Is our service adding value to people's lives? Is it adding value to your patients' lives? Is it adding value to your lives? The questions, feel free to participate in answering them, but I'm not going to answer them today. That's other sessions that we can have. Okay, so this is essentially what a person will get. When they are assessed, we do use a Macmillan tool called the concerns checklist. If that's what a person wants us to use, not everybody is able or has the capacity at a point in time to engage in a concerns checklist. But here is an example to show you the range, the wide range of things that we will help a person explore. Okay, we listen to them to discuss what matters to them, and then we help them plan things that could help alleviate anxiety or get them moving more, or support access to energy bill management and all these types of things. When we triage people, we make a tangible connection by referring people to the services that can help them. I know signposting used to be very popular, and when a person tells them all they want from us is a telephone number and to let them know about a service, that's great. We can absolutely do that. But there are a lot of people who don't have the confidence to connect themselves to services, or really are just in a point in crisis at certain points. So we coach people into these referrals with life skills and coaching skills. And we also help people by staying joined up with the referral partner that we've sent them to. Okay, so what are the most common concerns people talk to us about? None of these things will surprise you. Now, money is the top concern. This is primarily at the moment the services used by Dundee City citizens, people affected by cancer in Dundee City. I would suggest that across, when we get more people using the service across Tayside, we might find that money is number 3 on the list. Across all of the UK, it's number 7. In terms of a priority. But at this point in time, this is the highest concern people have. So you'll see the highest referral partner we have is welfare rights and benefit support. It will make sense when I show you a few other slides. But really, people are very anxious when they talk to us, and they're anxious and they're uncertain and they're having problems with sleeping and moving and low mood. So these are the types of things that we try and connect people to support. I'm sorry, the writing is going to be a little small for some of these slides, but really you can get a sense of this is the type of stuff we connect people to. It's a really big range of things, welfare rights, hope projects where there are local charities or third sector organizations that help people get the housing support that they need. We have a strong relationship with clinical specialists, be it palliative or the clinical nurse specialists in the acute setting. Occupational therapies, we have relationships with these agents, and we support people through those agents. We have a great relationship with Maggie's, and along all of these type of partners that we refer people to, we work hard at maintaining a relationship with them so we understand where their waiting lists or there's blockages to access these services. And we're doing constant mapping to understand what are the gaps in the Tayside system and what could be a commission going forward. Often have meetings with chief execs of PCAVs, DVVA, and all these types of organizations to make sure that we understand what the structures and agents are across Tayside that can help people affected by cancer. But some of this stuff is still very difficult, and this is what we think we can do even better, and we're working hard to achieve. It's really hard to get people consistent access to support around their homes, and that's a range of things. It can be energy bills, it can be the problem that they have with getting upstairs when they're extremely fatigued or frail. Getting those right adaptations, being on waiting lists is a real problem. You could already be on a waiting list, but that's because you have a pre-existing condition. But when you then get a cancer diagnosis, it could change your criteria, and a lot of people don't know this. So we support with that. We support managing them, getting better access to the things that are available. They're not just difficult to get access to. Psychological support. I know Pascal and a number of other individuals will be mapping out the mental health support around, at least in Dundee, as a starter for 10. There is psychological support, but again, it's tricky to access. And when you're in crisis or with a cancer diagnosis, or you're crashing because you're a carer, we really do need better rapid assessment. Transport is a tricky one. Sometimes it's really easy to sort out, and other times it's very difficult. It depends on the rurality and all of the other community and often third sector support that's in place. So we become really good at knowing what's available and helping people to overcome that variation. Palliative and end-of-life care, again, is a tricky one. It's not that there is a fantastic palliative care across Tayside. It's really just getting the right access to it at the right time. So some of what we're working to really improve is this system of supportive care across Tayside, and becoming specialists at navigating it, weaving the networks together, mapping out what's there and shaping what's needed. Okay, so let me tell you a little bit about what people have said about our service. So far, around over 5 years, we've helped about 3,000 people with holistic needs assessments and getting them the support they want. People have said, yes, we definitely identified what they needed, and we helped them achieve the outcomes that matter to them. And yes, I'm using those words intentionally. I know they're very Scottish government words, but they really do matter to people. They liked our approach. We're practical, we're compassionate, we're flexible. We're absolutely passionate about having a zero tolerance to zero tolerance. You know, if you're in crisis and you're very frustrated with the system and you get angry, we will still listen to you. We have the time, we have the skill set, we have the knowledge, we have the compassion, we are here for them. They like that we have a therapeutic conversation style. They thought the onward referrals we made were useful and they made a difference. And they were satisfied with a number of onward referrals because, of course, we're worried about too many referrals, too much information, too many assessments and too many care plans. But they also told us they did prefer to be referred to us by a care professional, and they really wanted more of that interaction to be coming from social care. Okay. I know there's a lot of information on this slide. Happy to share this stuff with you, but there's a lot more work we can do to support people affected by cancer or any other long-term condition for that matter. When we asked people of their experience of our service and the wider cancer system in Tayside, they said really they hadn't heard about us. They wanted to be reminded about us. They wanted more stories about what's on offer. They wanted the information we share with them to be diverse, to be sensitive, and they wanted community champion connections, and they want buddies across the system to help them navigate it. Many people hadn't heard of a holistic needs assessment before, and they hadn't had one either. So we keep talking about holistic support and people aren't getting it. They wish they'd accessed the service sooner. They wanted more contact with our link workers, and they wanted that earlier access to our service to be better prepared for the treatments and the interventions available to them. They were unsure of the type of support that they could get access to. And they also wanted people to understand how exhausting it is when they're getting a diagnosis or going through treatment. They're being asked lots of questions. It's really hard for them. So they want also to know how and when onward referral will work for them. And that's upstream at an acute diagnosis stage, or it's in a GP practice, or it's at our stage when we're referring them on to people. Getting people ready to be referred feels like a really important thing. They wanted us to follow up on appointments. They want clinicians to give them follow-up appointments, and they want to know if interventions are actually successful. They're still feeling uncertain about that. They really do want a single point of contact, and they want joined up ownership of their care. None of this will feel unfamiliar to you, I'm sure. And they also are confused about a range of care plans they get. They still experience poor communication across systems. And a third of people we spoke to said they didn't have any care plans. Now, if you're diagnosed with cancer, you don't have a care plan, that's a concern. But if you're a carer and you don't have a care plan, that's understandable. Not necessarily right, though. So I think what you'll see here is the data telling us there's lots of more work to do, but none of this, I think, will be new news for you. So let me just tell you a little bit about what we have to provide people with this access to supportive care. We've got 5 link workers, currently 4.5 whole-time equivalents in place. And around about, we do around about 86 HNAs, holistic needs assessments a month. 60 a month, but we've got capacity for 86. Sorry, I hope that just basically all you need to know is we've got more capacity. We can do more for people. And around about 60% of people who learn about a service do actually take up a HNA. As I say, we're an opt-in service at the moment, but we still get do not attends or did not attend. And some of that's really just down to changing circumstances, completely understandable when you're going through treatment or you're non-curative. So there is a huge range of opportunity for people affected by cancer to be connected with our service. And at the moment, people getting referred to us and the nature of their cancers doesn't align to the incidence and prevalence of the types of cancers in Tayside. So really there, what we're saying is if you've got lung cancer, we know that you're more likely to be diagnosed at a later stage. So you really need to come to our type of service sooner, and people aren't. So we're working hard with CNSs and the different cancer pathways to get more consistent referral into our service. People also tend to use us during treatments. You'll see the second highest user group there are carers and families, which is fantastic. These are people that often get exhausted by caring, will come to GPs with that level of fatigue and exhaustion. They won't necessarily connect it to their caring role. Also, we've got a huge opportunity to support people at palliative care stage and also at diagnosis stage. It's a complicated area of balancing people feeling overwhelmed and not knowing what they need, but we definitely can support and coach people through that process. At the moment, most of our referrals come through clinical nurse specialists. That's fantastic. That's absolutely what we want. We have some reciprocal referrals with welfare rights and a single point of contacts. About 12, it's actually now 16%, sorry, of people self-refer, which is great. We will do advertising later in the year once the services are fully established, and hopefully that self-referral rate will increase. We also buy a service from Public Health Scotland to let people who are diagnosed with a cancer know that our service is available to them. So again, it's an opt-in, it's a picking up a phone thing, which again, not everybody will have the confidence or ability to do that. Okay, so we wanted to know from CNSs, why are you not all sending everybody diagnosed with cancer to us? So we asked a few questions. Do you at least know about a service? Everybody said yes. Do you know we're Tayside wide now? Yes, they knew about that. So what's stopping you from referring people in? Most CNSs said that it's because they think that they hear that the patient thinks they're not ready. So that's a bit of a concern for us. If a patient doesn't feel they're ready to be sent to our service, that is absolutely okay, it's to be respected, but it could be because they want to prioritize clinical treatment, which is, again, when you've got cancer, you're worried you're going to die, you need to get your treatment in, they're overwhelmed at diagnosis stage with information and stress and the emotional stress of being diagnosed. But there's a huge opportunity that we can help with that. So that's a bit of a catch-22 that potentially primary care could support with by talking about our service and letting people know that actually we can support with some of this stuff. very complicated slide. Sorry, a lot of information, but an interesting one. We know there's been a spike in referrals at the acute setting after pandemic. We know many more people are coming through with a later diagnosis. We're not getting commensurate referrals into our service with that 66% spike in people being diagnosed with cancer. We'll taper off, but what we're saying is the system's very busy in acute and we should be equally busy, and we're not. Okay, so how will we improve access? How are we going to get people learning about our service? This very thing, telling you about our service, really making sure that every professional group that is involved in a cancer pathway has the opportunity to talk about, have you heard about the ICJ? Because there's any number of touch points in a person's journey that they can come and use us. We really want people to trust our service and believe that we make a difference, that we add value. If you're going to ask me, Michelle, will you reduce the number of contacts a person's going to make with my GP practice? I do not have that evidence. I can reassure you, however, that people are finding our service valuable. We've also set up a Tayside-wide network agency learning group, so anybody involved in supportive care comes along and we figure things out together. We've already done a session on improving referral, happy to share that stuff with you, and improving access. There's more stuff to do. So this year we're going to do a follow-up survey to find out what people experienced about our survey and how we can improve. We've started the Public Health Scotland letters back in May for everyone across Tayside. We've got new leaflets and posters coming and we'll distribute them at a wide number of settings. Please get in touch if you would like to advertise our service or hand out leaflets to people. We've also got now new websites. They will improve, and we're going to do a film to help reduce stigma and psychological barriers to accessing our type of service. You might be used to using supportive care, you might be used to getting and claiming benefits, but what happens if you're not? This can be a real problem. I earn too much money, I don't deserve to use third sector time. Let's address that. Okay, so can we develop a referral mechanism where everybody gets referred to us to reduce unequal access or inequity of access to supportive care? So we're also looking at, okay, where do we sit with MDTs and people's wider joined up care opportunity? Okay, so that's me done. I'm going to stop sharing my screen and open up to any questions and the conversation, if you would like. Or is it just presentation only at this? Or put in the chat if you would like to ask any questions and I'll answer it. Nobody wants to ask a question. Everybody's absolutely clear on what our service does and what we're here to provide. Hi, unmute yourself, just come on in. Thanks for putting your hand up. But
that's okay, thank you. Sorry, I'm hearing myself twice.
That's awful, isn't it?
I'm Heidi Douglas, the board screening coordinator. Sorry, I'm getting flashes, but anyway, I'm just wondering, do you have any information about staging and referrals?
That's a really good question. I do to a degree. We can tell you where people are likely in a general sense, but not in a relation to how likely they are to access a service when they're at the staging. I can tell you that people are more likely to be diagnosed later with lung cancer. I've got graphs that can tell you that stuff, but I can't show you a correlation as to does that have an impact on when they access supportive care or should be accessing our service. If that makes sense, or did I understand your question right?
Yes, sorry, it's really painful hearing myself twice here.
I know.
So yeah, I think it was just more about, is there more urgency or less urgency related to staging, basically?
So I would say anecdotally, because I know you'll probably
Mm.
want some evidence around this. The sense of urgency, yes, it is relative. It is relevant in terms of a person accessing supportive care. But in terms of getting access to treatment, that would be a clinical perspective that I couldn't offer. I'm sorry, I might not be understanding your question accurately, but yes, staging in terms of where a person's at in their cancer diagnosis and the severity, if you like, of the risk of dying, or I suppose I could give you an example of where I think it's really difficult for our service to provide quick access to care. And I know this because my best mate's just died of secondary breast cancer. So if me as a lead of this type of service couldn't get my best mate to come and speak to this type of service, you know, she was diagnosed in February, she died at the end of April. It was incredibly difficult to get her to speak to somebody around her holistic needs, her husband's holistic needs, her kids' holistic needs, and think about that emotional stuff. She was focused on clinical appointments, on pain management, and also quite focused on listening to clinicians tell her what she needed to do, what was the priority. So again, that's absolutely okay. And from a clinical setting, I absolutely respect that. What I saw as a friend was a big gap in that very brief cancer journey of her getting emotional support, her husband getting the emotional support that potentially they could access and could have prioritized, but perhaps didn't get the opportunity to prioritize. So in that particular case, I think that's when there is an expediency, if there is a non-curative, I suppose, a state of illness, then yes, please ask people to contact us. We can support them. There are limited psychological supports across Tayside, but I'm sure we can help navigate that. So we got a couple of, I'm sorry, Heidi, I'm sure I didn't answer your question there, but I did my best. Okay, so there's a good few questions in the chat. Thank you. How can we refer? No, I'm sure that I probably didn't cover that in my eagerness to share statistics. So we do have a referral form. We have websites. Please use the referral form. But we also have leaflets. And if you would like leaflets, as old-fashioned as they sound, they have our referral form on the back of them, together with our concerns checklist, and we're happy to share referral forms directly with you by email. But really it's just sending us an email with a referral form, please, to our single email address. It is the Dundee City email address. Please don't be confused. We're still Tayside-wide. We just have a central point of referral management. So hopefully that tells you how to do this. Can we check if patient has had input, e.g., is it documented in the healthcare record? Okay, yes. So in the holistic needs assessment conversation, we complete a whole H&A care plan, and that goes on a Macmillan system at the moment called eHNA, and we can produce that care plan, and it's made together with the individual. We talk through what their options are and what things they would like to access. We talk about the concerns that they've raised, and we share that back with them, and with their consent we share with yourselves, the GP. Now, in some cases, like in Glasgow City, they're able to upload care plans to clinical portal. We're not that, we don't have that interoperability here in Tayside, but we're absolutely willing to share this care plan with you with consent of the individual by email. Okay, anything else? Can a patient carer access help and advice from you 24/7? Unfortunately not. We're an appointment-based service. That's a really good question. So we are 9 to 5, Monday to Friday, appointment-based, absolutely free. However, we are linked to Macmillan healthcare helpline, sorry, struggling to be articulate, and we do provide that information. Can you post email in here to refer? Yes, absolutely, I can do that. That's a great question. So any other questions or curiosity about being involved in little, but hopefully big potential to have impact and add value to people's lives? There's going to be comfortable with some silence for a moment? See if anybody comes up with anything. Can you support a cancer patients? Absolutely, we support relatives and carers, friends. So currently we have that capacity, as I pointed out earlier in a slide, we're doing around about 60 HNAs a month. We've got minimum capacity to support around about 86 holistic needs assessments a month. Holistic needs assessments take around about an hour, but they can be shorter or longer based on what a person needs and wants. And we also do follow-up conversations if a person wants that. And as I say, just do that coaching support into referrals that can really make a big difference. So we are here for everyone. We always seek consent when a person is talking about, as a carer, talking about the person actually with cancer. And sometimes we even do that assessment together with people as a family. We can do it face-to-face, and pre-pandemic that was the mainstay of our service offer, but obviously now we do a lot of assessments by telephone and people prefer that in some cases. We do find older people prefer to do it face-to-face, and people are occasionally more frail and they would like somebody to come and visit them, and we can offer that too. We are also expanding our services across prison settings. So we've just launched at Castle Huntley Open Prison, and we will go there. They've got a fantastic facility, a community centre there, and we can go and do conversations with people in that setting there, or we will have the facility at locations across Tayside that are health and risk assessed and approved safe spaces to have conversations with people. We would also very much like to explore if you would like to have us support you and people, your patients in GP practices, GP settings. So we're very similar to the social prescribers. You'll be very familiar with that model of care, and indeed in Angus and Perth and Kinross, our link workers are situated in the social prescribing teams, and we're working well with social prescribing colleagues to refer between each other. Now, I'm not sure how long I have, so if anybody is used to this session, I can carry on talking, or let me know if I need to bring this to a close. You want to drop it in the chat if I have half an hour or an hour. Okay, if there's no more questions and you feel you've got enough information about our service, then please do get in touch. We'd love to hear from you. We'd love to find out if you're curious about our service, if you want more information, if you want leaflets, posters, if you're happy that you know enough about our service to talk to your patients about us, that'd be fantastic. Okay, get in touch using the email that I've just dropped into the chat, please. But also, I'm very happy to share some introductory information as a wee package to you all via the email addresses that you subscribe to this group. Ellie, got your hand up, please do jump in.
Oh, thank you. I can't type this question. It's really great that there's this service for people who've got a diagnosis of cancer. Is there a lot of overlap with people who've also got non-malignant disease as well? I'm trying to think about how we could support other groups of people with non-malignant disease as well who might benefit. Absolutely.
So we would take a referral for any long-term condition at this point in time. So when you say non-malignant, I suppose I do have to, I'm not a clinician, so I'll need to check with you in terms of what you mean by that, but anybody with a long-term condition can absolutely access a service. We're having a lot of conversations with Health and Social Care Partnership leads around, you shouldn't have to be diagnosed with a condition to access this type of service. We're a key connector. We help you navigate complex health and social care systems, get you the support you need based on the concerns you have. And it shouldn't matter if you have cancer or COPD or frailty. What we do want to do is make sure that adult assessment is appropriate for you where you're at in any one condition. So probably giving you more than what you were asking there, or not answering you correctly, Ellie.
No, that's really helpful, because I think all, you know, I've recognized several names here. We all look after people with various things which might contribute, and there might not be a malignancy, but people still have really significant life burdens, social, housing, all sorts of things, which a service like this would be brilliant. So the fact that we could refer for a non-malignant condition at this time is really helpful.
Absolutely, Ellie. So I'll just repeat or reassure you around that. It really doesn't matter what condition you have. What we find with people in terms of their concerns is they're often very similar, and there is a finite package of supportive care out there. You know, so if it doesn't matter if you're cancer or COPD, if you've got a housing issue, you've got a housing issue. It doesn't really matter. It might change the focus in terms of if you have lung cancer or you're palliative, how quickly we can get you access based on a point system if we're trying to support you get better housing or more appropriate housing. So in some cases, the nature of your illness will influence the processes and the conditions or criteria to access certain things, but we can help navigate that.
Great, thank you.
So we've got hello, you don't want to use a name, and that's absolutely fine. You used the service when you were diagnosed, but you weren't told about the service by a clinician, healthcare staff, but by another patient. I wish I'd known about the service earlier. It was a very lonely time. I am so sorry you experienced that. Absolutely understand. We wished you'd used us earlier too. So everybody on this call that's a clinician, please let people know about our service. We make a difference. We can really help people. And if there isn't a tangible referral we can make, we can listen to people. We offer a fantastic therapeutic conversation just to hear people and their concerns. And often people tell us that that made the difference. That is what they needed. They just wanted to talk to somebody, and we have the time and we have the skill. So if you're a GP and you're busy and you've got a 10-minute consultation, please mention us to people. We do make a difference. Thank you for dropping that in the chat. That was so important to hear. Well, we do work with people with long-term mental health conditions, but to be very clear, we're not a statutory mental health provider. We're not clinicians. We will recognize the difference between a long-term mental health condition and anxiety-related stuff based on a diagnosis of cancer or caring for someone with cancer. Two very different things. So if you have an existing long-term mental health condition and then diagnosed with cancer, and then you're anxious about dying because you have cancer and you need psychological support or befriending service or reduction in social isolation, we'll get that. But if you're in crisis because of your long-term mental health condition, we'll absolutely steer you directly to the appropriate statutory service. If it's an immediate crisis, we ask for a welfare visit from police. If there are problems and suicidal thoughts, again, we do that, or we can contact the appropriate statutory emergency response. So hopefully that was a good enough answer to that one. So lots of thank yous, and thank you also for adding two very important chats messages, even though I was saying I was leaving. So I will leave now, but please do contact me. I've put my email address in the chat. We'd love to hear from you. You're very, oh, Shannon's coming in with a, oh, is a clap? Not a hand up. Okay, awesome. Thank you, Shannon. Thank you so much for your time. We know you guys are busy, but please believe in our service and let people know about it. Thank you, and have a good rest of Thursday.